Dr. Bello, representing Professor Isaac Adewole.
I bring his greetings. He acknowledged the effort of Dr. Olajupo in trying to get him to attend this meeting, and also Dr. Shodipo, because they were on his, and he really appreciates them. The title of the presentation is Challenges of Healthcare Delivery in the Country, the Role of Private Medical Practitioner. Having listened to the chairman and also the president, they've actually discussed about 50% of the slide. I will just back it up with facts. I will also, towards the end, respond to the chairman's challenge, because I'm privileged to be a member of the Medical and Dental Council of Nigeria. I'm also a member of Medical and Dental Practitioner Tribunal, which has a status of a high court. And in fact, we just finished our last sitting 2 weeks ago, where we tried over 20 cases. We share some of the experiences. So this is my name. I'm very far in the pecking order from Professor Adewole. So I may make some mistakes. That mistake is me, and any good things I said then is from him. Greetings from the University of Ibadan and then the University College Hospital. I will talk briefly about 5 or 6 things, looking at the characteristics of developing country, healthcare delivery using some facts, the challenges that are peculiar to developing countries, using Nigeria as a case study, what should be the role of private medical practitioners, some recommendations, and then concluding remarks. This lecture is the 13th in the series of Adewole Memorial Lecture. Just to summarize that he was a very fantastic physician based on what I read about him. And he passed on in 1987. And as a mark of respect, this lecture is used to remember his good legacies as a former president of the ANPMP between 1976 and 1986. These are the previous lectures and cover virtually all aspects of health, ranging from non-communicable diseases, infection, modification, environmental changes. And I also noticed that this lecture has some national spread in terms of lecturers, which is very commendable. That shows sensitive to the heterogeneous state. To start by saying that developing country as a definition is a country that's usually a sovereign state, but they are classified based on the industrial state of that country and what we call Human Development Index. Countries with low HDI are often graded as developing country. But we now know that there are now, according to World Bank, that there are 4 different categories where countries are described. There is what we call the high income country, upper middle income country, low middle income country, low income country, and of course, the least developed countries. Most of the least developed countries have problem of governance, problem of disruption, problem of economy, and problem of health and lifestyle. And these countries are usually categorized based on 2 clear indicators. In the past, they used to use gross domestic products, but now they are now using GNI. So, next slide, yeah. So you notice that most of the countries in sub-Saharan Africa, starting from Western Africa here to the Horn of Africa here in Somalia, and part of Southern Africa form the sub-Saharan Africa. And then, of course, these countries are largely least developed countries. Whereas, but of course, with improving economy, change of governance, stability since 1999, Nigeria and some other countries are now categorized as low-middle income countries. And most of these low-middle income countries are also in Southern Asia. I've talked about this. So what are the characteristics of a developing nation? Usually, there is lack of basic amenities. For example, I marvel when we see our politicians come around, pipe-borne water. They just get public toilets. These are supposed to be a given amenities. You are not supposed to be commended for that. You are not supposed to be, but this is what we use as dividends of our democracy, and it shows our development. In developed countries, these are not used. Now, because of poor roads, poor transportation, even the railway system that the federal government is using now as their campaign strategy is also a given. Many of us have been to England. We see that there is virtually no area where you get to that there is no train station or there is no bus stop, and you know when the next bus is coming. You can plan your journey. So these are issues that you can use to describe a country. Of course, the air pollution is another issue. We don't care. You know, people take out different type of car, and when a car is stopped on the way to say, look, the exhaust is bringing out a lot of smoke, the average comment that will come up from a Nigerian is that, what is your business about that? But we now know that from science that children who are growing up are not supposed to be inhaling this. Even the elderly people are not supposed to, because this has a long-term implication on our health. Life expectancy, high fertility, lack of access to make decisions about family planning, of course, lack of power. I always tell people that any serious government that is coming should just do one point agenda: fix electricity. Every other sector will get fixed. Lack of electricity can be, it can be associated with health, it can be associated with education, it can be associated with anything, any development. And it has remained an albatross for us in Nigeria since independence. Now, there are 9 key issues that are social determinants of health in any nation. And these issues are access to healthcare, housing, income and job security, mental health, isolation, environment, education, and food security. So we should not always look at health as illness. Health should be looked in an holistic way in order to know whether a nation is a healthy nation or is a sick nation. It's not only when you fall sick and have malaria that you are ill. One can have a mental problem, and the next moment the person may be talking, the person may be driving, and that's why most people that are driving now, you know, in some state they will say you go and do mental health assessment if you drive against a traffic light or if it's a one-way whatever, because in a sane country that can never happen. If it happened, what that country will do, they will deploy their security system and lock down that area that will say, is our state going to be attacked? But it's a routine in Nigeria. In fact, some of us will say, because I have something very serious to do. But that time, your judgment is deranged as of the time you are taking a wrong decision. And that is why some states will say that. So health should be looked at in a very broad way. Now, the other issue is that what also affects the health of a nation is instability in government. Instability in government, like I said, we have enjoyed smooth transition, and I hope in 2023 we also have another transition so that we continue to stabilize the health system. Now, in 2015, at Assembly, when the Million Development Goal was, when they were, the governments that signed the Millennium Development Goal found that realistically we are unable to meet all this demand. Then they expanded this issue and started a process of sustainable development goal in 2015, which has about 17 targets and 169, which has 17 goals and 169 targets. But of interest to us here is SDG 3, SDG 2, SDG 5, and then of course 11, climate change, water, virtually all, except the one that is related to the chairman, peace, justice, and institution. That's SDG 15. So for the purpose of this lecture, I will highlight challenges of developing country using facts from Nigeria. Now, there are different data, but what we know now is that we are only around 50 million. It has been projected, if we go at a rate of 5.3 fertility rates, that by 2030, Nigeria will be hitting 400 million. Are we ready? Do we have that resources? And by 2050, Nigeria will be 733 million, according to the Lancet that was commissioned by Nigerians, which was commissioned by Vice President about 2 or 3 days ago. Nigeria will be hitting close to 1 billion anytime after 2050. Now, what is going to happen if we are not taking this serious? So now Nigeria is a country within a country. There are over 347 ethnic nationalities. We are very complex. And that's why I also get surprised when our commentator compare us with monolithic economy like Norway. How many ethnic groups are in Norway? How many ethnic groups are in Netherlands? How many ethnic groups are in England? Even London, England and Scotland are already, they are not talking together. Just two ethnic origin. But in Nigeria, we have over 347. Now, we need to understand this in what determines what Nigeria is currently passing through. Religion, we are diverse. We are not practicing the same religion. Compare ourselves to Rome or Saudi Arabia, where over 90% are either Muslim or Christian. So, if you see any African man anywhere or any African woman anywhere, 1 out of every 5 is a Nigerian, any black, where you get to. And I've tried it. You see that Nigerians, we are very blessed. We have very good environment. 36 states, 774 local governments, over 9,000 words. So, and you can see the chaos of Lagos. You can also see the serenity of Abuja. And then you can see the extreme of the village. But above all this, we are also a happy people. Now, I've talked about this population. I've also talked about this. And I've said that 43% of Nigerians are living in rural environments. I will relate this in terms of disproportionate access to healthcare shortly. Now, this is our fertility. It has stagnated over the years between 1950 and 2020. You can see we are hovering around 5.3. Now, Nigeria is a typical country that youth bulge and very narrow. And then, of course, if you look at the low income, middle income, upper income, high income countries, you can see where Nigeria is in terms of population. So Nigeria is actually the first Africa in terms of absolute figure. Now, in terms of education enrollment, you can also see that in the early 2000s, education enrollment in Nigeria was almost close to 45%, but it has dropped, and we need to do something about it. What about the healthcare system? The healthcare system, COVID actually exposed us that we had a very fragile, weak health system. Again, with all humility and then respect to all the people that have passed on from COVID pandemic, but we also saw from this COVID that it challenged us to also invest in our health system. And you see government, because most of the people that were affected in the early part of COVID were very, very important personalities. And many of them were now willing to push out money, advocate for health, and then you see government invest in intensive care units, investing in oxygen plants, investing in capacity building. Of course, despite this horrid investment, it's still not enough. Currently, the highest budget that Nigeria has ever witnessed is between 5.6 and 16%, 6%, and that was in 2015. But again, it dives again to less than 5% of the total budget. Now, in terms of the cost of health in Nigeria and the amount released, the blue are the cost of health. Look at it, 4% of what is needed, 5% of what is needed, 5.7. The highest was in 2015, 5.6 of what is needed. So health is actually an orphan within in Nigeria. In terms of health spending, and the chairman has said this, I'm also happy that the NHI's senior staff is here. I'm sure for us to have health for all, we need to make health available. And how do you make it available? Health insurance. And that's why health in England is one of the best health systems in the world, because they have an NHS that runs almost on autopilot. And their services is offered to, the same service is offered to the rich and to the poor. We saw it when Boris Johnson had COVID. He was taken to St. Thomas Hospital. That's just like being taken to UCH, not a private hospital or flown out of the country. So Nigeria is currently access health by out of pockets. And when Nigeria was compared to other countries, look at it, Nigeria, Ethiopia, and India, out-of-pocket expenditure in Nigeria is roughly 77%, whereas in India is 62%. And look at Ethiopia, another African country, 35%, meaning that over 60-something% in Ethiopia can access health without have to pay at the point of care, meaning that you can go to the hospital, you do not have to hold money. And this is one of the major issues that needs to be resolved. It's also important for us to note that our key indicators are not doing well. Our health key indicators are not doing well. We have one of the highest mortality in the world. Our life expectancy is very short, 54 years, compared to the average of 55. Infant mortality is one of the highest. And then, of course, this figure, despite being a poor figure, there are still inequalities within it. And I will show some data. Now, if you look here, in terms of antenatal, skilled birth attendants, immunization coverage, we are just flattening out. We are not improving. And that's why the agency, international agency, that's supposed to be supporting us for vaccination, at a particular point in time, withdrew their support because our DP3 vaccination, before Gavi can support any vaccination intervention, your DP3 should be above 65% or sometimes 70%. We are not there. In some states, we are up to 80%, but if you look at national average, some states are doing badly. In terms of antenatal coverage, antenatal coverage is about 2/3 of people in urban area compared to about less than half in rural area. Now, in terms of investment in health, now, when I'm talking about our role, I will see that, and I'm also happy the president mentioned it, health is a good business. It's properly planned, and you have a proper business case for it. So you can make money out of it. You can also make goodwill from it, both. But in Nigeria, you can see here, out of pocket is what happens. Our health insurance, I will talk briefly about it, is still not very good. Now, in terms of public investment in Nigeria, in relation to GDP, you can see Nigeria has a very high GDP, but look at health expenditure, it's very low. Now, is health investment in health good or not? It is. For every $1 spent in ensuring that women use contraception, there's a return of investment of 120. For every $1 you invest in malnutrition, there is a return of investment of $45. For every $1 you spend on putting health infrastructure in public space, there's a return investment of $49. Meaning that when there is a healthy nation, you have prosperity. There is potential for prosperity. I've discussed this. So, in terms of health insurance, I'm sure our guests can update this figure, whether, but we are still less than 10% conservative. So, we are less than 10%. And there are so many resources that Nigeria could tap on. I remember clearly, because I sat on that committee when Professor Adewole was minister. We explored the possibility of tobacco tax. We explored the possibility of tax from aviation. We explored the possibility of tax from luxury. There are some items that will be labeled luxury, and it is done all over the world. Like, for example, if somebody can go and buy a wine of 70% or 70,000 naira, that person should pay like 50% tax or something like that. Or because that is luxury. So now, if you stay in luxury hotel, they collect VAT, and this VAT can be, part of it can come to health. We did this that time, but of course, I'm sure the current administration may also be pursuing it. So the health currently, the health insurance, we are focusing on civil servants. Many states are starting their own state health insurance. But I must warn that they need to key into the national program so that we do not run parallel activity. We have a focus, and through better coordination, then coverage is, if all the states can also put by the government. Now, what is affecting health insurance generally in Nigeria is issue about sustainability. The CEOs, sometimes when they come around, they come with different. But now I'm aware they are trying to put up strategic framework that could outlive the government and ensure continuity even after this. Well, I've talked about we're a high producing nation. We do not use family planning. Only 43% of our women are delivered by skilled birth attendants, so maternal mortality will be high. Now, this is one thing that I know will interest the audience. In terms of primary health care service in Nigeria, about a third of primary health care services that are offered in Nigeria are offered private. You can see secondary health care, private is almost times 3 of what happens in public. And then, of course, almost equal is tertiary. So meaning that as a private practitioner, you can actually determine where you want to operate and make it clear the environment and do it well. Now, in terms of health facility, we have health facilities. Now, where I would say we have health structures, because when you say hospital, it's not the building that makes the hospital. Like I always tell people, I can deliver a woman in a vehicle. If given the right environment, I can do a cesarean section there if there is need for it. So having a nice place with air condition does not make that place an hospital. You need equipment, you need manpower, you need training. And this is the spread in Nigeria, very low. It's also important that the private sector and government need to come together if they are to have a good healthcare system. If you look at the governance structure of the health system in Nigeria, Federal Ministry of Health is in charge of primary healthcare development agency for primary healthcare, states, and then local government. But many of our teaching hospitals have been converted to primary healthcare center. There's no need for a woman with malaria to go to UCH, for example, unless that woman has malaria, cerebral malaria. Even cerebral malaria can be managed in a secondary healthcare facility. Now, because we do not have efficient primary healthcare system, and we have epileptic secondary healthcare system, the tertiary center are overwhelmed. I'm talking about public. Now, this is an opportunity for the private sector to key in. And there are some countries that have managed to work with private sector to set up a primary healthcare system. For example, the GP practice in UK, for example, is not government hospital alone that is offering that service. They are mostly private practitioners. And this is an area that where 84% of healthcare needs are offered, but people are not investing in it. There's nothing stopping a doctor who has money or has resources to establish to say, I want to partner with Oyo State to manage all their primary healthcare center in Nigeria as a company. You can write that proposal, and if you write that proposal to government, government can say, okay, we'll be collecting your royalty, and this is how much you can, then you can work out the operation. It's possible. But I'm not aware there is any state in Nigeria where such is happening. This thing with a secondary healthcare facility, there can be partnership between the private and the public. So, in terms of distribution of physicians, there is also inequality within the field that we had. 70% of medical doctors serviced 46% of the population. In fact, that is why ANPMP tried to categorize Lagos as a region separate from Southwest, because the number of doctors in Lagos alone is more than the number of doctors in some region in Nigeria. Now, is it that we do not have plan or policy in Nigeria? Look at our history. The first health policy was in 1962 to 1968, 1970 to 75, 75 to 80, 81 to 85, 1988, and then we started the National Health Policy Act, which was launched in 2014, and implementation started in 2016. One of the things that is supposed to offer is what we call Basic Healthcare Provision Fund. Now, that Basic Healthcare Provision Fund, certain percentage of that money should go to National Primary Care Development Agency, a large percentage should go to NHIS, and 2% for emergency. Government is just trying to start it. And I believe the private sector, you need to quickly engage with the Honorable Minister. You need to engage with the NHIS. You need to engage with the National Primary Care Development Agency before they start this implementation, that you participate and get involved. Let your members tap from this money. It's Commonwealth. Use it. If you use it to invest, of course, it's Nigerian that will benefit. So this is the gazette of that, the National Health Act in 2014. And you can look at the provisions there. Look at it, primary healthcare providers. So you are part of the people that should benefit. Even traditional healthcare providers, alternative healthcare providers have found their way into it. But I will suggest that we need to work at the national level fast. So this is where I will conclude by saying that private medical practitioners, you are a key member of health system. You are recognized by law. I just showed you the gazette. You are involved in all the levels of care. You are essentially fee for service, and you can also now you can also offer training. A lot of private institutions are training house officers, they are training resident doctors. So you are covered. And some of you also engage in public health in terms of offering immunization, family planning, COVID testing, TB testing. So these are other things that you can get involved and get partners with the government. So my recommendation is that professionalism is very important. I will now speak as a member of MDCN. I want to suggest that we need to go, we should encourage our members to always go for CMEs. I know in some states they are very, very strict about it. At least I can speak for your state. I've been a former secretary of NMA Oyo State. I know that AGPMPN in Oyo State is very vibrant, and I expect that in other states too. So, continuous medical education is important. Medical education keeps changing, and now we need to also be careful about use of ICT. Again, I'm also a member of a committee that is looking at the regulation for telemedicine. Many of us consult with our patients on phone. We consult with our patients on WhatsApp. We consult on our patients using Zoom. Many of these has legal implications. For now, I will advise us to tarry a bit. I'm sure before middle of the year, a regulation will come out, and there are a lot of requirements that you need to ensure in order not to fall foul of the law. Now, if anybody has faced the tribunal before, even if you are acquitted after, the torture you will have passed through in terms of passing through the investigative phase, the trial that can only be determined by the lawyers, and that could be for months or years, and this is not a daily tribunal. So, as much as possible, we should not dabble into areas we're not sure of. I know many of the private practitioners are the ones that are usually tempted to offer VIP services. Public institution, you are restrained. For example, I'm working in UCH now. I cannot say I want to go and see my patient at home as a doctor of a public institution. But if I have my private hospital, I can say, oh, chairman is a big man. I know him. He's a friend to my boss. Let me go and treat him at home. And then over the phone, I'll be dictating prescription. Doctors do this. Lawyers don't do that. My cousin is a lawyer. When I wanted to sell my car, he did, or what do they normally do? Transfer of ownership. I paid. The 2 days after, he came to my house with his son that was having fever. And I also said, are you going to pay or not? And he returned my money anyway, 2 days after. So doctors, we need to be very professional. And that further reinforces what he said about seal. Sir, I'm promising you, the next council of MDCN, I will raise it as a memo there. We are going to meet in June by God's grace, and I will raise it. Because it's something I know NMA has raised it. When I was NMA secretary in Oyo State, 2006. We raised it that time, we should have a seal. But there was an issue of the legality of an association, or the regulation should be the one that should have seal. So I think our own is slightly different from the NBA, where the association has power on some other things, disciplinary issues and things on their members. Whereas it's MDCN that have disciplinary issues. You can only report your member to, if it's professional. So I think it's something we can. The other bit is investment. The era of the alpha and omega of my hospital is gone. We need to do what we call joint practice. With all due respect, apart from one of my teachers that is here that has a very 5-star private practice, because when I went to his hospital to operate as a resident in some years back, everything in his hospital, I don't want to advertise, was disposable. From the brush that you used to scrub. Not everybody can afford that if you have not worked in where you collect pounds or dollars. So you can come together and do a joint practice and establish a state-of-the-art, like one that was just that was just established in Lagos. If a patient comes to the hospital, the environment enough should send some signal that there is hope here. Not you get to an hospital where you don't know whether this is really an hospital or it's not an hospital. So that is one thing. The second is that we should be clear about our service. To me, if you have a facility, you can just run a clinic. Let it be a clinic. For example, we know of a renowned professor in Ibadan that ran hypertension clinic. Hypertension, if you treat hypertension alone, people know you. That's what you do. You develop over the years. You see that service will blossom and then you expand. So investment is very important. Partnership and branding is what I've just talked about. We can invite entrepreneurs. I had the opportunity when I went for a fellowship program in Stellenbosch University in South Africa. The best hospital in Cape Town where doctors go to do locum, and my professor go there to do locum, is owned by someone that is not a medical doctor. And he established that state of the art. People go there, do their practice, and leave. So there's nothing stopping us from wooing entrepreneurs to come and establish hospital, and you can buy shares there as a clinician and also run it, and they pay you salary, you collect your dividend as a businessman. So era of a doctor being comfortable. When you say comfortable, I tell people is relative. We have doctors that goes on first class when they travel. There's nothing saying that because you have MBBS, you cannot go on first class and travel when you want to travel. So we must have that sense of entrepreneur. And then reversal of medical tourism. If we up our game in terms of service, of course, people will come in. And I just spoke about telemedicine, electronic medical record. And of course, as healthcare provider, we need to offer corporate social responsibility. This starts from head talking on radio. Invite us, let us go. And I've had to challenge some programs that they offer on some radio station. There was one guy that is always very popular program. I don't want to mention the station. I think it's usually the program held last night. The man always sexual education, talks about sex between husband and whatever. And then he says some things that are not correct. Around 11, I was in my library, I was reading. I just called him and I mentioned my middle name. And I told him that what you said is, this is this, this is this, this is this. He suspected that I'm a medical doctor. He called me after the program. Are you a medical? I said, yes. This is, we should show interest because it takes, it makes more sense if a doctor call in when there is a health program. Even all this, they will take sometimes when they call them into a program. You can phone in. Let's create time and offer this social responsibility. We'll see that we'll be helping people that are very important. So in conclusion, private medical practitioner represents, my boss say, a small but increasingly strategic component of the health system. You are very strategic and they are critical in complementing the public health system. A partnership with them could address some of the unfavorable conditions. Thank you very much.